I'm going to go through and show you kind of a virtual simulation of how we would position for finger, thumb, and hand. So this would be the typical x-ray room. You've got your patient sitting at the table here. One of the first things when we talk about extremities is talking about using the image receptor on tabletop instead of in the table bucky or the wall bucky. So what we mean by that is here's the image receptor underneath the patient's hand. It's sitting right on top of the table. Instead of being inside of the bucky, it's tabletop. So our SID is going to be 40 inches to the tabletop or to this image receptor here instead of in the bucky, which usually tends to be about a difference of 2 to 3 inches. This patient is sitting at about 90 degrees to the table, and there's a couple different reasons for that. One, it's a little bit easier to kind of extend your arm out in that 90-degree position and have your forearm and elbow kind of resting on the table instead of it being extended and straight out. The other reason for that is if the patient is sitting 90 degrees from the table, then the radiation isn't coming directly at their face, their eye tissue, their breast tissue, their thyroid tissue, or gonadal region. Um, Typically in x-ray rooms, they've got her sitting on the edge of the table. Typically we don't do that. We sit them on the end of the table like that, and she'd be facing towards the screen, towards us, and her arm would be extended at 90 degrees and her hand would actually be pointing towards us. This is just a different way to do it. Usually if you do it down at the other end, it gives you a wider range of motion because the table can go back and forth. So patients seated, we would put a lap shield over their lap. By the book, we use an 8x10 portrait. However, most plates now are DR plates are 14x17, so we would use our 14x17 image receptor and then we would collimate to the anatomy. So our tube set at 40-inch SID. With the tube on tabletop, we don't have to be in detent because we are going to manually center this tube to our anatomy over the image receptor. We don't have to be centered to the bucky to make sure that everything's aligned. So we don't have to worry about detent, transverse detent on tabletop work. So I'm going to push play here, and this is going to kind of move through a little bit. I'm going to zoom in a little bit on the anatomy so you can kind of see it from different angles and perspectives. So we'll zoom in here just a little bit closer, and it's going to show you where the central ray point is on the actual finger itself. So you can see how her elbow's kind of bent there at 90 degrees, resting on the table. Her hand is on the middle of the image receptor. And when you look in the book, it'll tell you to put the long axis of the finger, so the length of the finger, with the long axis of the cassette. So that's kind of what we want to do, is make sure that the long axis of the cassette and the long axis of the finger are going in the same direction. So our central ray point for the PA finger, this is a PA finger of the left hand, our central ray point is going to be at the PIP joint. So as I kind of zoom in a little bit there, sorry, there's a learning curve with that. I'm going to pause it right there for just a second. So we use an 8x10 film size, we collimate to the finger. Our KVP range is usually going to be about 50 to 60. Our SID is going to be 40 inches from the tabletop. And then the patient, like I said, will be seated at the end of the table, elbow flex 90 degrees. We need to include the entire finger and 1/3 of the metacarpal. We don't need to get all the way back to the wrist. We want the entire phalanges and 1/3 of the metacarpal. So for the PA, our central ray point is going to be at the PIP joint. PIP stands for proximal interphalangeal joint. So in digits 2 through 5, we have a DIP joint and a PIP joint. So this is the distal portion of the phalanx, the middle, and the proximal. So the DIP joint is the distal interphalangeal joint. So it's the distal portion there. The PIP joint is the proximal interphalangeal joint. And then we have the MCP joint, which is the metacarpal phalangeal joint down here. So we're always going to center at that PIP joint, or essentially the second knuckle here. They're a little off-centered here. I would want my central ray point coming down right in the middle of this finger. Now where they're at's okay, but I'd run it kind of right down the middle of the finger, just a little bit more towards this side, but at the level of the PIP joint. The marker placement's important. You want to have the marker there, but you always want to be careful that there is space. In the real world, you'll see a shadow of the finger overcasted by the light. You want to make sure that that marker is not in the shadow of the finger at all, or it's going to end up in the anatomy. So we collimate closely on each border here on each side to make sure that all of the anatomy is included and the other digits are out of the way. We don't want this third digit to be really close here and in the light field. We want them as separated as possible. So I'm going to kind of zoom in a little bit to show you some different perspectives. And then I do turn on an anatomy camera so you can kind of see where the bone structure is. So right here, now you can see. So here's the DIP joint right here, the distal interphalangeal joint, and here's the PIP joint where we center, the proximal interphalangeal joint, and here's the MCP joint, metacarpal phalangeal joint. Here's the entire phalange, and then here's the metacarpal right here, starting here on the rounded portion. So we get about 1/3 of that. We want the entire joint. Anytime we're x-raying something that has a joint attached to it, we need to include that entire joint space and the anatomy that articulates on the other side. So that's why we need about 1/3 of that metacarpal. We don't need to go all the way down or include all the way to the carpals for that. So I'll kind of move around a little bit here so you can see it from different angles and perspectives. So you can see centered again right over that PIP joint there. Now here's the x-ray that we would look at. This is what the finger x-ray would look like. So you can see the distal phalanx, the distal interphalangeal joint, middle phalanx, the proximal interphalangeal joint, proximal phalanx, and then the MCP joint or metacarpal phalangeal joint. And then here's the second metacarpal. This is the second digit, so that's why it's the second metacarpal. So on that PA view, we want to ensure that, like again, I said that the fingers are separated so there's no overlapping soft tissue. See the soft tissue from this third digit here? If those fingers were close together, this soft tissue would overlap. So spread those fingers apart. And then we want to make sure that the interphalangeal joints appear open. So if there's any angle or if the hand isn't completely flat on the image receptor, then those joints aren't going to be open. And we really want to make sure that the joints are open because there can be little fractures inside of those joint spaces that if it's closed off, we wouldn't be able to visualize and we could miss. So we'll go back to the x-ray portion here, the imaging portion in just a second as we get out of this. So again, here's our central ray point, the PIP. Okay, so again, this is how we center, this is how we collimate, getting 1/3 of the metacarpal, making sure that we have light off the tip of the finger. We should have equal borders on each side of the finger and not any other of the digits or soft tissue in the anatomy. Left marker should be close, but not interfering with any of the soft tissue. So I'm going to change it over to an oblique, and this is a little bit different. So as they zoom in and out on this one, so what you can see here is they actually have the collimation open all the way up for a hand. It shouldn't be open that much. For an oblique finger, we want to oblique the hand about 45 degrees, and we can do a couple different things here. So the second digit can actually be rotated medially, but digit 3, 4, and 5, we rotate laterally. And when I say medially, that would mean rotate this hand towards the medial side of the body, so you'd be rolling this down. These ones are rotated laterally right now. The whole hand is rotated laterally or out. So this light field is open way too much. They need to collimate down. They're x-raying the third digit right now, so they're centered at the PIP joint for that, and they should collimate down. The reason for possibly rolling that second digit medially is because of the OID. Let me hit play again here and move this around. So when I go to the front portion of it, you can kind of see how high off of the IR this actually is. Look at the space we have here. right? Look at how much OID is between that second digit and the image receptor. So to eliminate the OID, we can actually roll that second digit medially and it wouldn't be that high. And again, even here, like on this third digit, we could have brought that down to the second step here, still used it oblique, um, used it to oblique the finger, but less OID. This is what we call a step sponge. The step sponge will actually angle the hand 45 degrees so that you don't have to think about, oh, am I rolled about 45 degrees? These are radiolucent, which means that they will not be visualized on the x-ray. So we can use them underneath the patient's anatomy and they won't be seen. So this is kind of a poor representation of a finger, but you would be centered at the PIP joint for this third digit. You'd be collimated in. The marker would be a little bit closer. Like I said, even this pinky here, if you were x-raying the fifth digit, you could leave that pinky right there. It's already rolled 45 degrees, center on the PIP joint, collimate right down to that anatomy, and then put your left marker there and you'd be all set. So I'm going to move this around just a little bit more, and then I'm going to turn it into the skeleton view again so you can see where some of the anatomy is. So they're centered right over that PIP joint there of that third digit, centered right down the finger. They just need to collimate. So again, you can see right here on that skeleton, they're centered right over here on the third PIP joint. Here's the DIP joint, distal interphalangeal joint, and then the PIP joint, proximal interphalangeal joint. And you can see here on the oblique finger. So it's really important to make sure that when we're obliquing the finger and taking that x-ray and we collimate down, that there's no superimposition or overlapping of the adjacent tissues or fingers. This one's kind of close here, but we want to make sure that we can see the digit that we're trying to look at free of any other anatomy that's overlapping it. We also want to make sure that the IP joints, the interphalangeal joints, and the metacarpal phalangeal joints are open, which means that the phalanges are actually parallel to the IR instead of being angled down. So I'm just going to kind of move around again for you to see some different angles here of what it would look like to be in that oblique position. So the hand's kind of rolled up at about 45 degrees. Again, no overlapping tissue or bones so that we can see the area of interest free of any different anatomy. So this one actually shows you the entire hand. Again, it should be just that digit. So the difference of the anatomy here is you can see this concave area here on the anterior surface. The concave area is going to indicate to us that it is a good 45-degree oblique. Again, we're making sure that there's no other anatomy that's obscuring the area of interest that we're looking at. It's going to go back in just a second. We'll go back and look at the hand again. And then we're going to move on to the lateral position. So the lateral digit, we want to still, again, center at the PIP joint and then write down the digit, making sure that the marker is out of the shadow of the anatomy. We're going to get back to about 1/3 of the MCP joint again. Now, we can't do anything about those fingers that are going to be bent over. We just want to try to pull them back as far as we can out of the way, maybe even using our thumb to hold them in that position. So you're going to do the same thing no matter what finger it is, fourth, fifth, third, or even the second. The only difference with the second digit is there's going to be a lot of OID if you leave it in that same position. So what we would actually do is roll our finger over, all the way over, so that that second digit is as close to the IR as possible. So it would be a a different view. The third digit, the fourth digit, and the fifth digit we would position just like this. Third digit, either way you rotate the hand, there's going to be OID. So it's what's more comfortable for the patient. So I'll kind of go around again and show you different perspectives and angles of what it would look like to position that fifth digit. We want to ensure that it's a true lateral position, making sure, a lot of times I use the nail bed as an indicator unless the patient's nails aren't, normal, but that nail bed should be perpendicular to the IR here. So we want it completely lateral and perpendicular there. So in just a second here, after I show you some different perspectives, I'll turn on the skeleton view so you can see where the central ray point again is. See, here's your DIP joint here, PIP joint nice and open. We're going to center right over that, and we're going to get about 1/3 of the metacarpals here. Like I said, we can't do anything about these joints here, or the bony anatomy here. We just want to try to pull it back the best we can to get it out of the way. And again, making sure that that marker is not in the anatomy. So to ensure that that finger's kind of in a true lateral position, you can kind of see here. So you can tell again here by this concave appearance on the anterior surface of the phalanges. So we want to make sure that this is in a true lateral. And also that the joint spaces are open, which is indicating that the patient's digit was parallel to the IR. And I'll keep playing that again to give you different perspectives. You also want to make sure that the hand is truly lateral here. You want to make sure that all of the metacarpals are superimposed over the top of each other, because if they're rotated a little bit, that means the patient isn't in a true lateral position. So here's the x-ray of the lateral finger, and like I said, you can see here by that concave appearance a little bit that it's in a true lateral position. We want to make sure that these interphalangeal joint spaces are open. So you've got the distal phalanx, the DIP joint, the distal interphalangeal joint, middle phalanx, the PIP joint or proximal interphalangeal joint, which is where our central ray point is. We're getting the entire proximal phalanx and then at least 1/3 of the metacarpal, and then also making sure that we have the MCP joint or metacarpal phalangeal joint on there. All right, I'm going to move into thumb real quick. We'll move on to thumb here in just a second. So everything with thumb is going to be the exact same as far as positioning the patient, getting them on the table, setting him at the end, elbow 90 degrees, 40-inch SID to the tabletop. You'd use an 8x10 and collimate to the anatomy. So all that's going to be the exact same. One of the differences, normally for like a finger or something like that, we start with the PA, then we go to the oblique, and then we go to the lateral. With the thumb, it's a little bit different. I tend to start with the oblique position, and the reason for that, this one actually starts with the lateral, but the reason that I start with the oblique is because if you lay your hand flat on a surface right now and you look at your thumb with your palm down flat on the surface, your thumb naturally is in an oblique position when our hand is PA and flat. So a lot of times when I have my patient just set their hand right up there, the patient's already in an oblique position and I can start right with that. It doesn't really matter what you start with, but it's just something that's a little bit easier for me. So the thing about the thumb that's different than the finger is the thumb only has one interphalangeal joint. It doesn't have the distal interphalangeal joint and the proximal. It just has one interphalangeal joint. So we call it the, sorry, just one second. Okay, so since the thumb only has an interphalangeal joint, a lot of times they consider the metacarpal part of the thumb. So what we're going to do for the thumb is we're going to center at the MCP joint, the metacarpal phalangeal joint right here, instead of at the PIP joint because there isn't a PIP joint. So if we centered at the IP joint, we wouldn't get all of the entire metacarpal. So we center at the MCP joint, get the entire thumb, and then for the first digit, we're going to get all the way back to the carpals, so the CM joint, the carpal metacarpal joint, CMC joint. So I'm going to play this again, go through and have a little bit different perspective for you so you can kind of see. This is a true lateral position. So they've actually got the hand built up here so that you can keep it in that lateral position and the patient doesn't move. When I show you the positioning video, I'll show you a way that you can actually use the fingers and kind of bend the fingers up to hold that position as well. So in just a second here, it's going to go through and flash to the skeleton view. All right, so again, when you're looking at the thumb, I was trying to get it in a good view. So you can see here, here's the interphalangeal joint. So because there's only one joint, this is the IP joint. This right here is the MCP joint, the metacarpal phalangeal joint. You've got the metacarpal, and then you've got the CMC joint, the carpal metacarpal joint. So for the thumb, we're going to get this entire area all the way back to the carpal. So you'll get the CMC joint and the carpal bone in that. That's why we center at the MCP joint for the thumb. So for the lateral view, you want to make sure that the thumb is in a true lateral position. And again, you can tell by that concave portion here on the anterior surface of the proximal phalanx and that first metacarpal area. You also want to make sure that the IP joint and the MCP joints appear open. So move this around a little bit again to get you a little different perspective. So here's the x-ray. So again, here's that concave appearance of the phalanx and of the metacarpal that's kind of showing us that it's in a true lateral position. You can even kind of see the nail bed here to be able to visualize that it's in a true lateral. So you've got distal phalanx, the interphalangeal joint, proximal phalanx, MCP joint or metacarpal phalangeal joint, the first metacarpal, and then the CMC joint, carpal metacarpal joint. So the differences between the finger and the thumb is you were missing that middle phalanx and the PIP joint. We'll switch back here in just a second to the skeleton view and the regular anatomy, just kind of zooming in some different areas so you can see that. So you can see that the interphalangeal joint was a little bit open there. This one, the metacarpal joint, is not. All right, so we'll zoom back. And then you can see again here, we're centered right at that MCP joint on the thumb. Collimation on both sides, making sure the marker's not in the anatomy, light all the way back to the carpals. This is what it would look like on the skin. And then we'll switch to the AP view. I don't think actually, now that I'm thinking about it, I don't think they have in this anatomy app, they don't have the oblique thumb, which I think is why I didn't start with that. So this is your AP thumb. So it's a little bit awkward. We actually do AP as opposed to PA because the PA view would have a substantial amount of OID. So we roll that patient's hand over onto their nail bed to get an AP view to get the anatomy closer to the IR. So again, we're still going to center at that MCP joint. We rotate the hand internally, place that posterior surface on the IR. We want to ensure that there's no rotation. You can tell on the x-ray, and I'll show you when we look at it, is by the concave sides on each border of the phalanx and equal amounts of soft tissue on either side. And we also want to make sure that that IP joint is open. So on this one, they have a left marker and then they also have an AP. That's not always necessary. You might not see that in your clinical sites. So we want to make sure there's light off the tip of the finger so that we don't clip any of that anatomy, and then light all the way back until the carpal area so that we can make sure that we have the CMC joint. So it is a little bit awkward of a position. If your patient was ever unable to do this, then we could do a PA instead with the OID. So you can see here they're centered at the MCP joint. You've got the interphalangeal joint there, and then centered at the MCP joint with light all the way back to the carpal so we can see the CMC joint as well. All right, so looking at this x-ray, this is what I was talking about. You can see the concave sides on both sides of the phalanx. That's a good indication that there isn't rotation. And then also it should be equal light on each side of the thumb. So this one actually has a little bit of rotation. And I can tell because look at the soft tissue on this side of the phalanx versus the amount of soft tissue on this side. There's much more. So that patient's actually rotated a little bit. And if this line wasn't here, you'd also be able to see a little bit of the thumb pad here, which is indicating that there is slight rotation in this x-ray. Now, some facilities might not make you repeat that, but just to let you know, there is a little bit of rotation here. The interphalangeal joint, MCP joint, um, and then the carpal metacarpal joint, and then the carpals where they articulate. So the routine views for the thumb are the AP, oblique, and the lateral view. So the PA is only done in the event that the patient cannot perform the AP view. So I'm going to stop that right there, and then I'm going to move into hand, and we'll break down the hand as well. Okay, so for the hand x-ray, we do a PA, oblique, and a lateral. Patient's going to be positioned exactly the same, usually like I said at the end of the table though. Lap apron across them for radiation protection. We're using a 40-inch SID to the tabletop. The only difference with the hand is depending on the patient's hand size, you use either a 10 by 12 or an 8 by 10. We usually stick with a 10 by 12. But again, like I said, a lot of the new DR plates are just 14 by 17. We use one plate and we collimate to the anatomy. So you're going to collimate on all sides without clipping off soft tissue. So I'm going to hit play here, and this is going to kind of zoom in again. We'll give you some additional information on the hand here. So our central ray point for the hand is going to be at the MCP joint. So it's going to be at the third MCP joint for the PA and oblique, and at the second MCP joint for the lateral. Our KVP ranges to about 50 to 60. So when we position for the PA, we want the hand flat on the IR, as flat as we can go. We don't want our fingers bent up because that closes off the IP joint. So we want everything nice and flat. We're going to position at the third MCP joint right here, so over that third knuckle. And then we want to collimate on all sides. So we want to make sure that we have light all the way through the carpals and, including a little bit of the radius and ulna there so that we have the entire joint. We're going to collimate on all borders, make sure that we're not clipping the thumb. We've got a little bit light past that, past the pinky, and up towards the top. We could collimate down a little bit here, but central ray point should be at the third MCP joint right there. All fingers should be spaced out. We don't want our fingers close together because then our soft tissue is going to be overlapping or superimposed. So move that around a little bit just for that additional perspective. All right, so right there you can kind of see where we're centered over that third MCP joint, exactly where we're centered. If we center over the third MCP joint, then it's going to help to make sure that all of the other interphalangeal joints are open and well visualized. All right, so I'll show you an x-ray here of that. So like I said, we want to make sure that we get here, we're centered at the third MCP joint right here. We want the entire hand. We want all the way through the carpals, and we want the ulna and radius to make sure that they're included in there. You don't need much of them. You just need to have the entire joint space area between the carpals and the radius and ulna so that we can make sure that we have everything on there. So again, fingers separated enough where the soft tissue here on each side isn't overlapping. The thumb is going to be in an oblique position no matter what we do, so all of the rest of the hand is going to be PA, but that thumb is going to be in an oblique position. We'll go back here to the regular anatomy in just a second. All right. So again, centered at that third MCP joint with collimation to all borders, so you're not clipping any anatomy. So this is an oblique hand, and you can do an oblique hand in two different ways. Depending on whether you're wanting to visualize the metacarpals or the phalanges. So if their phalanges at all are an area of interest, this isn't going to be proper positioning, because if you watch how these fingers kind of curve down or angle down, what's going to happen is because these digits are not parallel to the IR or lifted up off of the IR, these interphalangeal joint spaces are going to be closed off. So we're not going to be able to visualize if there's any trauma or any fractures or anything like that going on in those interphalangeal joints. So if we're concerned about the digits at all, then we need to make sure that they stay parallel to the IR. But again, we're going to be centered for an oblique hand here at the third MCP joint. So I always say it kind of comes in a little bit between the second and the third. You're not centering way over here on the third. You're kind of centering where it would enter at the third MCP joint. Make sure that you don't clip off the thumb. The collimation light field is open so that it includes the thumb, the pinky, and then off the tip of the fingers. And we have the entire carpals and the radius and ulna included in there. So I'll move this around again a little bit here. So you want that hand in a good 45-degree oblique. So here again, you can see we're centered right over that third MCP joint. But see how these fingers kind of angle down? See what happens, how it closes off those joint spaces? If that finger was straight out in an oblique position, when the central ray is perpendicular to those joint spaces and that finger is parallel to the image receptor, it would keep those joint spaces open. So after a second here, I'm going to bring up the x-ray so you can see that. Okay, so you can see here, look at the difference between the joint space here, the DIP joint and the PIP joint, versus here, where this finger is angled down. Now, the problem with this x-ray too is these joints, or these fingers, are superimposed over each other. They should have been more separated out so that they weren't superimposed. But this is the difference of what happens when you angle the finger down versus when it's parallel. You know, we don't want those joints to be closed off. We want to be able to visualize them. We'll go back to the regular anatomy, and then we're going to move on to the lateral hand. So moving on to the lateral, this one even again is a little bit different. So what we normally do, the routine view for a hand lateral is the fan lateral. So what that means is these fingers are fanned out. So usually I have the patient kind of make an okay sign, like, you know, the okie dokie, and bring these fingers kind of closer together and then fan the rest of these out. We're going to center at the second MCP joint, which is right here, but we want to make sure that all of the metacarpals are superimposed over each other. So there's a perfect lateral position and not rotation, so they're separated. This one actually is a little bit rotated and it's not quite a true lateral. You can also tell by feeling the wrist if the patient's a true lateral, but you can use the sponge here for stability if the patient needs it, but I don't always use a sponge. I try to get the patient to hold that position the best I can. So I can see here that it's not truly lateral. So you can see right there, this is what I'm talking about. So see, you've got second metacarpal, third, fourth, and fifth. You can see them all kind of in that step pattern. They should be all on top of each other and completely superimposed. So that patient actually needs to roll their hand back just a little bit more to get all the metacarpals right on top of each other. So you can even kind of see that they're on a slant instead of being right on top of each other. If that wrist was in a true lateral position, the hand would be in a true lateral position as well. But keeping all those joints on the sponge keeps them parallel, which means that the interphalangeal joint spaces would open. So on this one, you can see the difference. This is not a fan lateral, so they don't have the digits fanned apart, but this is what a true lateral should look like in the metacarpal area. See how all of them are superimposed? Most facilities aren't going to do a hand like this. They're going to, the metacarpal should be lateral like this, but then the fingers should be fanned. But this is a good indication of what it should look like to be truly lateral. And you should be centered right at the second MCP joint. So they're not really centered where they should be. They should be centered right over the second MCP joint. Okay, so I just wanted to have something for you guys to go over, a little bit of positioning. This will be available to you. You can watch it if you want. I'm also going to do an overview and a recording of our lecture on Friday.